Good afternoon, everyone. This year, we celebrate a milestone year for the Ray Symposium. It is my honor to welcome you all on our campus in Pomona, as well as those in Oregon, for the 20th annual Ray Symposium. Yes, it's a milestone. And this is in honor of our second dean of our college, Dr. Max Ray. He's Dean Emeritus, Max Ray, and he is in the audience today as well. I'll call upon him in just a few seconds to say a few words. Those of you who don't know me, my name is Sunil Prabhu. I'm the fourth dean of the College of Pharmacy. Dr. Ray was dean from 1999 to 2006 and is credited with developing and leading the growth of the college during its early years. Dr. Ray has spent over 50 years of his career in patient care, specialty residency programs, and serving in academic pharmacy as an educator, researcher, and mentor. In recognition of his tremendous contributions to the profession of pharmacy and to the college, Dean Emeritus Daniel Robinson, the third dean of the college, who is also in the audience today, established the Ray Symposium. Thank you, Dean Robinson. The Ray Symposium was established in his honor 20 years ago, a tradition that I am proud to continue as dean. I'm happy to state that Dr. Ray is also in the audience, as I just mentioned, and I'll call him momentarily. I do like to first acknowledge some of the dignitaries in this audience. We have our former Board of Trustees member, Linda Krantz. We have our provost, Dr. Paula Crone, who will say a few welcome words soon. We have Dr. Nisi Cornish, who is our Chief Operating Officer. We have Martha Rivera, who is our liaison for external affairs, right? Dr. Andrea Jafrida at the back, VP of Research. Oh, Liz Andrews, Dean of the College of Dental Medicine. I'm trying to see if anybody else I'm missing. Dr. Henson, Vice Provost. I don't want to miss anyone. Josh Matakota over there from the College of Health Sciences. Thank you all for coming. Welcome to all our Oregon campus. I think Dr. Phipps is in the audience from the Oregon campus as well. She's the site dean for that campus. All right, and then I do have to recognize our sponsors, because without the sponsors, these won't be possible for us to do. So the first thank you is to Max Johnson, who used to be a resident with Dr. Ray, and thank you for his sponsorship of this event. Of course, our friends from Walgreens, Ralph's, and Blue Shield of California, thank you so much. And to my Dean's Advisory Council, all of the members who, through their generosity, continue to support not just this event, but many other events in the college. So thank you so much. Our president, Dr. Faris Eisner, could not be here today, so I'm going to call on our provost, Dr. Paula Crone, who has kindly agreed to say a few words on behalf of the university. Dr. Crone.
Thank you, Dean Prabhu. On behalf of Western U, I want to welcome all of you to the 20th year of the Ray Symposium. 20 years is very remarkable. Congratulations, Dean. Our Oregon campus, thank you for joining us today. And our Western U community, which is represented, if you think about having 3 deans from the College of Pharmacy, our College of Pharmacy is 30 years old this year, and we have 3 of its deans in the room tonight with us. I think that's remarkable. Dr. Robinson, Dr. Ray, Dean Prabhu, 2, 3, and 4. Let's give them a round of applause for their leadership. And then 20 years of the Ray Symposium, 20 years of exploring new ideas, new thoughts, bringing expert leaders from around the nation to come to Western U and share their expertise, share their knowledge, be thought provocative in their worldviews, and bring those ideas to us. So without further ado, I'm going to turn this back over to Dean Prabhu so we can hear from our outstanding guest lecturer today.
Thank you, Provost Crone, for your kind words. Before we actually bring our guest out, I would like Dr. Ray himself to say a few words to this audience.
No speech this year. Just a cordial greeting to each of you. I'm glad to be back with you again this year. Thank you, Dean.
Thank you so much, Max. All right, our next dignitary is Miss Elena Robles. She is Senior District Representative who will say a few words on behalf of our State Senator, Susan Rubio. And I think she has something to give us as well.
Thank you. Good afternoon, everybody. It's an honor to be here on behalf of State Senator Susan Rubio. She is a member of the Health Committee, and so she is very vested on health. As you may or may not know, she's been a teacher for over 20 years. And so everything that she does it because of what she learned being a teacher and now being in the State Senate. She has a passion for helping people. And when she visited here last year, I was fortunate enough to tour the facilities with her, and it was amazing. She was very impressed. So she wanted me to come out here and congratulate Western University and the College of Pharmacy, especially because of the work you're doing, the innovation, everything that's happening here. It's amazing. So I did bring a certificate to honor the 20th annual Ray Symposium. Thank you for putting it on and bringing it 20 years ago. And just to congratulate you, I also brought a certificate honoring the keynote speaker. When he comes out, maybe he could grab it. But just know that the senator extends her well wishes and wishes that this program continues to grow and whatever you need to do.
To our guest right now, if you could.
Perfect.
Yeah.
Oh, come on up.
And we can get a picture done with Jeff.
Thank
you.
I was very impressed when I was reading that. Yes.
I appreciate that.
All right. For our audience over in Oregon, once the talk is done from our speaker, if you have any questions, please post it and I'll read those questions out for Dr. Carroll. Now, for the main event, it is my distinct pleasure to introduce today's speaker, Dr. Aaron Carroll. You've all seen his impressive bio, but I'll briefly summarize here. We actually first met him at the AACP meeting in Chicago last July. He was our keynote speaker and spoke over 2 plenary sessions. And of course, were very, very impressive and had the audience completely enraptured. And so I reached out to him afterwards and I said, would you mind coming for a milestone event for our 20th anniversary for the Ray Symposium? And he graciously agreed. So he is here today to talk to us about that. You'll see that he uses no slides. So there is not going to be PowerPoint slide presentations, okay? Now, let me give you a little brief summary about him. He is currently the president and CEO of Academy Health, a nationally recognized thought leader, science communicator, pediatrician, and health services researcher. He's a passionate advocate for the creation and use of evidence to improve health and healthcare for all. Before joining Academy Health, Dr. Carroll was a Distinguished Professor of Pediatrics and Chief Health Officer at Indiana University, where he also served as the Associate Dean for Research Mentoring and the Director of the Center for Pediatric and Adolescent Comparative Effectiveness Research at the Indiana University School of Medicine. He earned a BA in chemistry from Amherst College and an MD from the University of Pennsylvania School of Medicine, and an MS in Health Services from the University of Washington School of Public Health, where he was also a Robert Wood Johnson Clinical Scholar. Dr. Carroll's research focused on the study of information technology to improve pediatric care, decision analysis, and areas of health policy, including cost effectiveness, care and healthcare financing reform. He's the author of The Bad Food Bible, a regular contributor to the New York Times and The Atlantic, and he's co-editor-in-chief at The Incidental Economist, an evidence-based health policy blog. His talk today is on science you can trust, that's on the board, leading with evidence in a distrustful time. We'll have some time, as I said, free for questions and answers after his presentation. And before I start, I'd also like to recognize our Dean from the College of Osteopathic Medicine, Dr. Warren. Thank you for coming. All right, with that, please welcome Dr. Carroll to the stage. So
you can all see me better over there. Thank you. Thank you very much for that introduction. It's an absolute pleasure to be here. I'm going to stand in the corner here because while I don't use PowerPoint, it's helpful just to have some notes as I speak. But again, I'm very excited and honored that you all have me here today. So in 2018, there was a landmark study published in The Lancet. It was the largest study ever done on the dangers of consuming alcohol. And basically what they did was they did a meta-analysis of every other study that they could find, looking at 23 different related diseases and how likely you were or were not to get those over the course of the year if you drank alcohol. The final results were that obviously drinking alcohol is not good for you. I mean, it was, even going into it, you knew where that was going to go. And the headline results said, if you drink 1 drink per day, your risk of getting one of these 23 diseases goes up 7%. If you drink 2 drinks per day, I'm sorry, that was up 0.5%, but it's real, 0.5%. 2 drinks per day, it goes up 7%. If you were to drink 5 drinks per day, which nobody recommends, your risk of getting one of these 23 diseases went up 37%. All the headlines proclaimed, no amount of alcohol is safe because drinking even 1 drink per day statistically raised your risk of getting one of these diseases. It made lots of news. And it really started spurring lots of different organizations and even the Surgeon General just over a year ago to say that we need to put new warning labels on all kinds of alcohol and say that drinking any alcohol is unsafe. And it was followed up by my least favorite phrase on earth, follow the science. I wrote an article in the New York Times when this study came out, which took the exact same data, the exact same study, using their numbers and presented a slightly different argument. If you take 100,000 people who drink no alcohol at all, 914 of them will get one of those 23 diseases over the course of a year, just by chance alone, because that happens. If you drink 1 drink per day, that number goes up from 914 to 918, meaning 4 people out of 100,000 may get one of those 23 diseases if they drink 1 drink per day. If you drink 2 drinks per day, that number goes up to 977. And if you drink 5 drinks a day, which again, nobody recommends, that number goes up to 1,252, which means that you're significantly more likely just to get one of these diseases by drinking nothing and chance alone than if you were to drink 5 drinks per day. But at 4 per 100,000, it seems like it might be reasonable to say that's a choice people can make on their own and that they could weigh it, that that's a pretty small number and that there are lots of risks in the world that are much higher, especially since the only thing they could control for in this study was age. There was nothing else they could look at. They couldn't tell where you lived. They couldn't tell what other health problems you did, whether or not you smoked, whether you exercised, what else you ate. It was just a huge gathering of data and putting it together. The relative risk sounds very scary. They start saying it's going to go up by 7% if you drink 2 drinks per day. On the other hand, you could turn around and say it goes up by like just a couple of people if you drink 2 drinks per day. One's going to make headlines. The other is going to perhaps give people a better look at what choices they might make when they make health decisions. I got accused, by the way, of misinformation and spreading it when I wrote that column, even though I pulled the exact same data out of the exact same study. Both of us are right. I'm not arguing that anything that anyone else in an article wrote was wrong, but there's different framing and there's different ways that different people perceive that. That gap matters. And it's what this talk is about and what I think we can do about it. Public trust in health institutions has been declining for a period of time. It was not caused by the pandemic, although the pandemic absolutely accelerated that. Only 23% of Americans have a great deal of confidence in medical scientists to act in the public interest, as of a poll in 2024, which is down 40% from 2020. So that has dropped significantly since the pandemic. This is not just a science problem, and it's not just a communications problem. It's also a leadership problem. When we default to fear-based framing, when we cherry pick evidence, or when we refuse to acknowledge trade-offs, we contribute to that erosion of trust. Today, I want to talk about 3 things that I think we can do to combat that. Lead with solution-focused research, embrace innovation with guardrails, and learn to communicate in ways that build trust. These are not just nice ideas. I think they're actually obligations. So let's start by talking about solutions-focused research. What do I mean by that? Too much research, especially health services research, which is my area, is about pointing out problems. You can't open up a journal in my field without finding at least 3 or 4 articles telling you how terrible the United States healthcare system is and why. You can find almost none telling us what we should do about it. For years, we have been publishing study after study after study showing about how terrible disparities in healthcare are and how terrible disparities are in every facet of medicine. We have done very little to publish solutions or things that we have proven will improve that. After hearing how terrible things are for decades, without feeling like there's going to be an improvement or what we could do about it, people start to think that this might be a waste of time. Solutions-focused research, on the other hand, needs to start with a problem that matters to real people, and then focus on what we can actually do about that in order to make things better. Let me give you a few examples. In 2002, the IMPACT trial was focused in JAMA, and it basically showed that in a randomized controlled trial, if we use coordination of care to care for depression in primary care, it actually results in improved outcomes. That we shouldn't just try to do this in one-off, that we really need to think about involving multiple facets of the healthcare system and making sure that they all work together in order to achieve their goals. That works. It's the reason that we do that today. But this was in 2002. It's been a long time since then. But this study just didn't document that there's undertreatment or document the flaws in the way that we do things. It actually tested a fix, showed that it worked, and then showed how we could scale it. It changed how we organize mental health care across the country and is now the basis for the coordination of care billing codes in Medicare. It changed what we do for the better. Research that solves problems has a policy impact. Research that only documents problems sits on the shelf and makes people upset if we don't actually act on it. But solutions-focused research doesn't just stop with the randomized controlled trial. It has to be moved into other domains. It requires implementation science and also looking at how things work in the real world. It also requires us sometimes to broaden our definition of what we consider high-quality research to make sure that we're capturing what works in the real world. A lot of this has been done in pharmacy. In 2015, a good study showed that pharmacy-led blood pressure management with medication in the VA significantly improved blood pressure control, involving pharmacists in the actual prescription and monitoring of patients in the hospital resulted in improvements. It was a rigorous test of a team-based model. A couple years later in the New England Journal of Medicine came out one of my absolute all-time favorite studies, which went a step further and said, why do we need the healthcare system at all? Why don't we try meeting people where people are? And they took pharmacists and they embedded them in barbershops, because that is where a lot of people, especially a lot of the African-American male population, spends a significant amount of time. And because of that, by meeting people where they live, and I'm just involving pharmacists, they made improvements in pharmacy management of blood pressure that exceeded the results of almost any efficacy trial I've ever seen for a blood pressure medication. We didn't need the healthcare system. We didn't need to have a doctor's visit. We didn't need to have even nurse management. Pharmacists embedded where people are made a bigger difference than almost anything else we could do. Now, that study again was in 2018. There have been limited efforts to try to roll that out, but they have not met with all of the hope that you might, because there are lots of other factors in the healthcare system that try to oppose people expanding their scope of care, of doing more without higher degrees or higher and higher and higher expertise. There's been pushback on the use of vaccination in these areas. And all of that is problematic, because what we need is not pointing out problems or thinking about theoretical issues, but focusing on solutions. And sometimes that means doing studies that show that things don't work. During the passage of the Affordable Care Act, there was a huge article published by Atul Gawande in the New Yorker that focused on high-cost individuals. And he showed that in certain parts of the country, the vast majority of healthcare spending was due to a few individuals. That the vast majority of people don't really account for much healthcare spending at all, but something like 5% of people can account for an enormous percentage of healthcare spending. And everyone got it into their heads that what we really need to do is focus on these high-cost individuals, and then we can reduce spending in the healthcare system. And so Amy Finkelstein and others put together a study that was published in 2020 in the New England Journal of Medicine that tried to do just this. It took places across the country and identified who the super utilizers were, and then tried focusing efforts on them to reduce hospitalizations. It didn't work, because it turns out that last year's super high spenders are not the same as this year's super high spenders. That sometimes super high spenders are people in the last 6 months of their life, and if they pass away, they're not there to spend a lot next year. And you cannot predict from the past necessarily who's going to cost money in the future. That's just as important. Telling us what doesn't work is massively critical in order to have the resources to focus on what does. But it requires us to then act. Too many people still talk about this as if it's a reasonably easy way to reduce healthcare spending. Let's just spend less in the last 6 months of life. Let's just spend less on people, but we can't predict that in the past towards the future. And so continuing to focus on it when we know it doesn't work leads us down blind alleys as well. Solutions-focused research has to be honest, it has to be rigorous, and it has to be interested in an impact and not just publication. What does it mean to embrace innovation with guardrails? Well, healthcare is one of those strange places that's simultaneously too slow to adopt what works and often too fast to embrace what's shiny. When I first started practicing medicine and engaging in research, I was super focused on electronic health records. They were just coming up, and I believed, along with tons of other people, that they were going to change the way that we practice medicine. And they have. They are the #1 cause of physician dissatisfaction in healthcare right now. They have caused burnout to skyrocket. They have not resulted in more access. They've rarely resulted in higher quality. The one thing that they've been shown again and again and again to do very well is help us upcode, so that we can be paid more for doing no more good for any patient in our hospitals or in our clinics. It's a necessary technology, though. We can't do so many things without the data collection that's there. But we were simultaneously afraid to get involved in its creation and how it gets implemented and how we pushed until it was too late, and then what we got didn't do what we needed it to do. I spend too many times going to meetings today, especially amongst the healthcare system, amongst those who practice in different ways in the healthcare system, and especially amongst those who research the healthcare system, where all I hear is fear and pointing out the possible problems and dangers of AI. And they are real. But once again, if we are only pointing out problems and not offering solutions, we're going to get passed by. Clem McDonald is a very famous bioinformaticist. He's at the University of Michigan, and he published a paper in, I think it was 2008, called The Fundamental Theorems of Biomedical Informatics. It was sort of a landmark paper in my field at the time. And his key point, the theorem, was not that machines are going to be better than humans, but humans plus an information tool should be better than humans alone. That's the goal. Not machines are better, not that machines are going to replace, but that humans plus information resource should be better than humans alone. And it had three corollaries. The first was that humans are more important in this equation than the machines, because the humans using the machines is what makes it different. The second is that the machines just can't give you stuff and information. That information has to be useful when you need it. And the third corollary was you cannot predict in advance how the human and the resource or the machine are going to work together, and that is paramount to whether or not all of this holds together. He was talking at the time about clinical decision support and electronic medical records, but it applies just as equally to artificial intelligence. I'm a journal editor at JAMA Pediatrics, and almost every single paper that someone submits to us, if it's an actual trial, is trying to get the machine to replace a human being in some way. Get it to write a note instead of having a doctor do it. Get it to have a talk with patients instead of having a doctor do it. It is still fundamentally not using the fundamental theorem. It doesn't recognize that our goal is not for AI to do what some of us in this room can do without us. It's how can we work with AI to have a better outcome than AI alone. But we're not going to get that way if we're not willing to embrace innovation in some way, if we're not willing to work with those who are leading the way in this innovation. It's obvious that large language models and clinical decision support, all of this is coming, and it's going to happen. And some of these studies are real, like a 2023 article in JAMA Internal Medicine was one of the first to show that actually physicians seemed the AI seemed a bit more empathetic and actually could do a good job in talking to patients in some way. But again, it's focused on the replacement. We need guardrails. What do guardrails look like in practice? First, we have to study things as they're being implemented before they're pushed out at large scale. We have to do pilot programs with built-in evaluation in order to make sure that these things function in our environment the ways that we want them to. The VA's query model is a perfect example of this because it embeds implementation scientists with projects from day one when they're doing any kinds of pilots to see how new information or how things can be scaled up in the future if they turn out to work. The second thing we have to do with guardrails is we have to measure what actually matters to patients. Too often our studies focus on what matters to a hospital administrator, or what matters to somebody who's in the budget office, or sometimes even what matters to clinicians, instead of focusing on what matters to patients. And that matters. I mean, trying to just do higher utilization rates doesn't matter if it actually doesn't translate into patient outcomes. And we will get lost if we don't keep our eye on the ball. The third is that as we do all these studies, we need guardrails which are going to watch for equity. The Optum algorithm, which was originally rolled out to a lot of fanfare because it was going to be great at predicting which patients needed certain medication for high blood pressure, turned out to systematically underestimate the needs of Black patients. That was partially in the way that the instructions were given and what it was taught to prioritize. And the good news is people went back and fixed that. The fix required changing what the algorithm optimized for. But if we don't think about this, as we deploy these kinds of technologies, as we roll them out, we're going to lose because we need to know how are these things functioning and make sure that we're not doing harm as we're doing good. The fourth thing we need to do is to iterate honestly. If something is not working, we have to stop, and we have to be honest about that. We have to adjust. That is not failure. That's how science is supposed to work. But we often don't apply those rules when we talk about innovation, especially with innovation and with information technology. We think that the cost of starting up is too high, the cost of implementation is too high, and once we've got something and it's not good and everyone hates it, we just keep pushing our way through. That is not the way to embrace innovation so that we do good for patients and so that we create a healthcare system which works for more people. All of you are probably implementing some new tool right now. All of you are probably thinking about, how can all of this new fancy technology be used in new ways? The question is whether you're doing it with or without guardrails, whether you're ready to focus on what matters, whether you're ready to scale it up if it does or does not work and stop if it does not. But I want to focus on the number one thing that I think is most important moving forward, and that's how we actually talk about science and how we talk about health, because focusing our research better is important, and making sure that we keep up with innovation is going to be critical. But all of that fails if we don't massively start talking about science and talking about research in better ways. So my first example was with alcohol. And the key point to take home is, why did the headline say no amount of alcohol is safe? Did so because relative risks make better headlines. What's a relative risk versus an absolute risk? Well, relative risk is how we compare what was to what would be. It is always universally more successful, more sexy and more likely to get a good headline than the absolute risk. A 50% increase in your risk of death sounds terrifying, but 50% is relative. If it was going from 10% to 20%, I also think that's terrifying. If it's going from 0.00001% to 0.00015%, that's not so terrifying. That's the absolute risk. Almost every single risk that you read in a newspaper or see online is a relative risk, because again, that's what's going to scare you, that's what's going to give you hope, that's what's going to sell. But it is not how we calculate the actual value to an individual, which is what most people care about when they are seeing you. This happens with cancer screening. It happens with drug risks and food scares and vaccine side effects. It also happens with stuff like food. I have written many columns about the risks and benefits of what people eat. It's what led me to write my most recent book. But meat is a great example. The WHO will tell you that if you eat meat, your risk of getting colon cancer over the course of your lifetime will go up by 18%. That sounds scary. It sounds terrible. And I have read many different op-eds in many different papers that say that people should give up eating meat because of this terrible risk. Well, there's a couple of things going on here. The first is, of course, that's a relative risk increase. The second is, and I don't want to belabor this, but it's very specific to red meat. It's very specific to processed red meat. So it's for things like bacon. But again, it's a relative risk. It also is what they think it is if you commit to eating one extra serving a day every day for the rest of your life. So if I agreed today to eat 3 more pieces of bacon every day for the rest of my life, my lifetime risk of colon cancer may, and I repeat may, because all of this is badly confounded epidemiologic research and not randomized controls, may go up by 18%. But what would happen in real life? I can go over to the NIH and I can plug my data about what I do with my life and how do I eat and what's my family history. And it turns out that at a baseline, my lifetime risk for the rest of my life of getting colon cancer is 2.7%. If I commit to eating 3 extra pieces of bacon every day for the rest of my life, and this holds up to be true, my lifetime risk of getting colon cancer will go up to 3.2%. That's not nearly as scary, 2.7 to 3.2 over a lifetime, as just saying 18%. Now, some people may feel that's too much, and they probably don't want to eat 3 extra pieces. I don't want to eat 3 extra pieces of bacon every day either, and I'm not going to. That's not how most people think about this. They're thinking about it like, can I have steak once in a while? Or can I have a burger once in a while? Which, by the way, this study, none of those numbers even apply to. Maybe they're thinking, maybe I'd like to have some extra bacon once in a while. That is still very different, and we don't know the answers. But it is too easy to just keep scaring people by pointing to the relative risk. There's a simple fix. Also talk about the absolute risk. You can talk about both. I'm not hiding one or the other. But one's going to give people something that they can use to make a decision about whether the risks and benefits to them are worthwhile. One of them also builds trust and gives people the full picture. And that's the one we should use. The second, and a failure we make all the time in science communication, is a failure to recognize the limitations of different study designs. Research is not research is not research. Some research gives us much better surety about the causality of one thing on another, and some research even gives us better surety about whether or not even an association is real. A case-control study is not the same thing as a randomized controlled trial. An observational cohort is not the same thing as a meta-analysis. We know this, but the way that we communicate findings for all evidence often talks about it as if all things are the same. When the pandemic hit and the original studies started coming out about hydroxychloroquine, they were not randomized controlled trials. They were sometimes cohort studies. They were sometimes case control studies. They were most often case series. But the press and lots of health officials talked about these as if they were all exactly the same thing. Is that me dinging? No. They talked about them as if they were sort of like research has shown, evidence has shown. And that was a fatal mistake because people started thinking in it. And then when the RCTs finally came out and showed no benefit whatsoever, well, the cat was out of the bag because research had already shown that it works. And it's very hard to bring that back. No one at the time was really saying out loud over and over again on TV, hey, look, this is super preliminary. Don't know, don't buy into this yet. We need to do follow-up studies. There's much bigger examples as well. You don't have to look to the pandemic for this. Tons of examples exist. Some of them are local to California. I think this is no longer true because I think that there was a federal case last year. But up until last year, you were following Prop 65 and its effects on whether something or not causes cancer. Well, first of all, who does California rely upon to say if something does or does not cause cancer? It's the good old WHO, the ones who say that 18%, your risk is going to go up 18% if you eat meat. The WHO has looked at about 1,002 different substances to see whether or not they might potentially cause cancer. Up until a couple of years ago, only 2 things were not found to cause cancer. One of them has changed, and I'll get to that in a minute. But everything else might cause cancer. Doesn't matter if it's a strange case series in rats or a huge case series in horses or a randomized controlled trial. If it has the risk of causing cancer, it goes on the list. Prop 65 says if it's on the list, you got to put a warning sign anywhere that stuff gets sold, which is why if you went into a coffee shop anywhere in California, you would have seen a warning sign saying, hey, guess what? Coffee causes cancer, might cause cancer because it contains acrylamide. What is acrylamide? Acrylamide is a substance that forms anytime you take a starch, any starch at all, and you bake it, you broil it, you fry it, you toast it, you do anything to it but boil it or microwave it. Any starch at all. More than 60% of calories consumed worldwide contain acrylamide. You can't make bread without making acrylamide. You can't cook anything that has starch in it without making acrylamide. It is impossible to roast coffee beans without making acrylamide. It's just not. You can't do it. There's nothing you can do. So why keep warning people about it? But it gets worse. The studies that show acrylamide might cause cancer are, of course, they took rats and they injected them subcutaneously with ungodly amounts of acrylamide. No one consumes acrylamide that way. I'm not recommending you do that. No one should. There are no human studies at all which say acrylamide poses a risk to human beings. If you go to the American Cancer Society website, which does not shy away from telling you about the stuff that causes cancer, it says there's no good reason to believe that acrylamide causes cancer in human beings. None. You can't make it. You can't make coffee without making acrylamide. There's nothing to be done. That's when it gets even worse. Because what is the one substance that flipped a couple of years ago where they said, actually, we're wrong, this definitely doesn't cause cancer? It's coffee. Coffee does not cause cancer. Up until a couple of years ago, the WHO said it, but there was sort of an outcry. I like to think I helped lead that because I've written a number of articles about coffee, but I'm sure I didn't. But they reversed themselves on coffee. But because of Prop 65, you got to keep putting up a sign in the window that says, even though we know coffee doesn't cause cancer, we got to warn you about the acrylamide in the coffee because over there, a very poorly designed study said that this might cause cancer. We have to start being okay with the idea that we need better confirmation of data before we overreact. There's an even better study. You've probably all heard of like wellness programs. These are things that jobs often do and provide you with the idea that they're going to make you healthy. They became a huge money-making business, in the early 2010s and then going on. And there were lots of studies which showed that businesses that provided work wellness programs to their employees saw a bunch of benefits. They saw that they reduced their healthcare spending when people used wellness programs. They saw when people used wellness programs, they were more likely to go to the gym. They were more likely to stay at their job. I mean, it was just top to bottom, lots of studies showing a benefit. Those who used wellness programs did better than those who did not. They were not randomized controlled trials. They were all cohort studies. They looked at in a workplace at the people that used the wellness program and the people that didn't. Well, those people might be different for other reasons. Maybe the people who go to the gym are more likely to use the wellness program to get a discount at the gym. And maybe the people who want to use a wellness program are healthier in general and therefore have low, we don't know. Then a bunch of people at the University of Illinois came up with an amazing study where they did actually a randomized controlled trial. What they did was they took a bunch of employees and they randomized them to whether or not they get offered a wellness program, and then looked to see if it made a difference. And it turns out in a randomized controlled trial, no difference at all. But it was a brilliant study because then they took the exact same people and data and analyzed it like a cohort study as well. They said, let's also look at the people who used the wellness program versus the people that didn't. And when they did that, huge differences, just like every other study, because it turns out to be true. The people who opt in to use the wellness program are different than the people who do not. But in a randomized controlled trial, no difference at all. We have spent billions of dollars on this. They're still being offered all over the country. Now, not as much as they used to. And people have shied away from it, especially since they've shown that it often works by cost shifting onto the sick. But we wasted enormous amounts of time because we didn't recognize that the study designs that were being pushed weren't adequate to the answers that we want. We have to be more honest about this. We have to be willing to say, this is preliminary. This is observational. This can show associations, but not causation. That's not hedging. That's being more trustworthy. Now, a third way that goes a little bit further is we often cherry pick. We pick the research that supports what we say, and we ignore the research that doesn't. We do this all the time. And when I say we, I don't just mean people and patients. I mean clinicians. I mean people who work in the healthcare setting. All kinds of people do this. You can look at e-cigarettes. And if you want to say, I think that these are probably a step forward, you focus on the studies that show harm reduction. You focus on the studies that show you're not breathing in the same toxins that you otherwise would. If you hate e-cigarettes and the idea that they're there, you focus on the research that shows that that's what they're targeting teens at the moment, and teens are turning to e-cigarettes now instead of using tobacco. Or you say that there's a lot of dual use, that some people use both. Now, both of those sides have evidence, but we should be able to talk about all of them together. Neither side tells the full story. Nowhere is this more evident again than in research. There's a burger place in our local mall that used to have all this stuff on the wall that was like all the ways that their burgers were good for your health. They contained onions, which reduced your risk of getting cancer. They had turmeric, which reduced your risk of inflammation. They had, this, everything. It was just amazing. And I'm like, it's a burger. Like, what are we doing here? Like, this is none of this. It's not a health food. And I'm fine with you eating it. Don't get me wrong. But it's like, know what you're doing. Let's be honest about it. There were some amazing researchers who published a study in 2013 in the Journal of Clinical Nutrition. They took The Joy of Cooking, a pretty famous cookbook off the shelf, and they turned to at the end, they had a list of ingredients, and they picked 50 ingredients at random from that. Then they went to the literature, and they searched for all the ways that studies might have been done to show whether these 50 ingredients cause or prevent your getting cancer, because it could be good for you or bad for you. They found 272 studies of these 50 different ingredients. Some of them which showed they cause cancer, some of which showed they reduce cancer. But what would blow your mind was they did what's called a funnel plot, where they lined everything up and you got a dot to one side if it was a study that showed it caused cancer. And the further out it was, the bigger the effect size. And on the other side, you got a dot if it prevented cancer. And the further out, the better it was for you. Pretty much every single ingredient had dots on both sides. You could find a study which shows it causes cancer. You could also find a study which shows it prevents cancer. Now, if you want to be honest about that, you would say we really have no freaking idea at all what these things are doing, that some of them cause cancer and some of them prevent cancer. Or maybe it really doesn't make much of a difference at all. Or really, it's probably impossible to do research on any single ingredient and actually determine if it causes something or prevents something that causes, that something's multifactorial as cancer. But that's not what we do. People cherry pick all the time. They'll tell you something's good for you. And this is what the media does too. Anytime there's a new study and it shows this causes cancer or this appears to prevent cancer, it'll be on a headline as if no research came before and nothing has ever contradicted it. That's what gets clicks. That's what sells people. It also convinces people that research isn't real, because for every study that they can find that something is one way, they can also find something that's the other. Instead of discussing things in totality, instead of always recognize what do we know up until this point, the public eventually figures out you're cherry picking and that you left something out. Systematic reviews and meta-analyses exist for a reason. It's because they're trying to pull all the studies together and give you a much clearer answer. Those are unfortunately far rarer than they should be. It's also because we often lack randomized controlled trials, which is really what you need to do a solid, good meta-analysis, because otherwise you're just pouring more and more data from a cohort study into a cohort study, which doesn't do anything but give you more statistical precision about a very small amount. People know this. They will learn it over time. And if you don't present all of the data, if you don't present the whole story, no single study can actually make your case. And if you don't acknowledge what you don't know or what else is out there, it gets hard. And it gets hard to keep up that trust. You need to be the person who says it's more complicated than that. Or you have to look at all the research together. You just can't pick one. Taking that a step further, often we will focus only on benefits or harms. And we don't take both into consideration. And every healthcare decision should be weighing what are the benefits from this and what are the harms from this. And then very rational people may make very different decisions based upon what is important to them. I have ulcerative colitis. I take a medication to suppress my immune system that has a very tiny risk of causing aplastic anemia, basically shutting down my bone marrow. My wife, when she heard it could shut down your bone marrow, lost her mind. It was like, don't take that drug. I'm like, I've been in remission for over a decade. You will pry this drug out of my cold, dead hands. I am going to take it, and I will have my blood drawn every 3 months, and I will live with this small but greater than zero risk of aplastic anemia, because the benefits to my life are so massive, they outweigh the harms. But rational people may choose differently. But too often when we talk about some of these things, especially in cancer screening, we only focus on one or the other. We say, do it, because early screening is the best, detection is the best. We have waffled up and back on things like prostate cancer screening for so long because we keep flipping from whether we care more about the benefits or the harms. Well, the most recent USPSTF guideline was really so much better than the past, because what it sat down was actually, it gave you the actual numbers of people that would experience both a benefit and a risk if you started from, say, 100 people. At the end of the day, it would say, like, if we screen 100 people, one of them may have a death prevented by prostate cancer. But it also said, but also 80% of 80 people may wind up with a diagnosis if it's positive and wind up with something like incontinence or an inability to have sex. You're being incontinent and both impotent or impotent. Well, those are big deals. And people will rationally make a decision that maybe that risk isn't enough than what I want to do over here. And other people will disagree. But it's important to weigh both. My favorite story of only looking at one side is, of course, in pediatrics, and it happened during my fellowship. It was the late 90s, and we had just had our first baby. I'm sorry, it had to be early 2000s because we just had our first baby. It was 2002. And the American Academy of Pediatrics all of a sudden really got it into their head of like, hey, you know what? We put babies in car seats in cars because it's so dangerous if they have an accident. You know what? We got to put babies in planes in car seats because if there's an accident, we got to prevent something bad from happening. And they all of a sudden started contacting all the members and pediatricians like me and saying, you have got to help us. We got to get the FAA to pass a rule that says all babies must be in car seats. And they wanted me as a pediatrician to start lecturing my patients about they better be putting their kids in car seats on planes. And they wanted me as a newborn parent to have to buy an extra ticket on a plane and put our newborn in the car seat because that was going to be safe. And of course, they went to one of my, again, least favorite lines, but anything to prevent one child death. It's got to be worth it. While I was a fellow, one of my fellowship mentors actually published a pretty impressive paper that was published at the time. It was Archives of Pediatrics, which is now JAMA Pediatrics. But they actually broke it down and looked at the actual numbers. And they said, if we were to make everyone buy a car seat and everyone buy a seat and put them all in a car seat, how many deaths would we expect to prevent over the course of the year? And it turned out not even to be 1, it was 0.4. So we would save 40% of a baby's life every year. So, okay, so over 2.5 years, we might save 1 life. Isn't that worth it? Well, they also checked out the cost. What would it cost to prevent that life? And it was billions of dollars in 2001 or 2002. It was a lot of money to say. Now, okay, maybe you're like, it doesn't matter, we're saving a life, but I could save a lot of lives with billions of dollars in much more cost-effective ways than this. But then they went further because there are unintended consequences. And if you don't consider potential harms, you're missing half the story. Some people are not going to do this, even if we pass a law. They're going to say, $400 to buy a ticket? No, I am not buying a ticket. We're going to drive. What's the #1 killer of small children? Accidents. Accidents. If they said if 5% of people choose to drive, it was a $200 ticket, 5% of people choose to drive, and they drive an average of 400 miles because they want to save that money, we will kill more babies than we will save. We will do actual harm. Now, to their credit, the American Academy of Pediatrics reversed itself, which is why we don't have any rule today about buying car seats on planes. And if you want to, I think that's great. But planes are pretty safe. And it turns out that we'd rather people fly than drive because it's way safer than driving. And so we want to incentivize people to get on planes, and making them charge extra money forcefully to put a baby in a car seat winds up to do more harm than good. But if we only ever focus on what are the benefits, or if we only ever focus on what are the harms, and we try to scare people or push people with that, we miss the whole story. This happens all the time. And it's much more complicated to talk about things this way than just get screened or don't get screened. But it's what trust actually requires. Every profession faces this. Pharmacists discussing medication risks, nurses explaining procedures, physicians discussing treatment, public health making population level decisions, because every decision has both benefits and harms, and it is rational that different people will make different decisions based on those. And it's important always that we talk about both. So how do we put all this together? First, we need to, again, focus on research that focuses on people's real problems and test solutions honestly. We have to be willing to engage with the new, with guardrails, to make sure that we're not falling behind, but also thinking about potential problems as we move forward. And we need to use communication that uses absolute risk as well as relative risk, that acknowledges the limitations of what we know, be okay to say I don't know, that presents all of the evidence, not just what we like, and that fully respects trade-offs and that people are going to disagree with it. The change management literature, if you dig into it, and there is a real literature, it's not just sort of like, what do we do, has a number of really great frameworks and ideas. And one of them is something I've really come to appreciate over the last few years. And it's a framework for why people refuse to change their mind or behavior. And it comes out, there's 3 reasons or 3 levels that people resist change. They don't understand it, they don't like it, or they don't like you, which is really about trust. We treat too many things, especially in health, as if it only falls into that first bucket. It's a knowledge dissemination problem. If we could just get people the research, they would change their minds. If we could just get people the evidence, they would do what we want them to do. We'll just keep telling them to do this. And when we get frustrated, we start saying follow the evidence or follow the science, and then we start trying to make them scared. It ignores that there's lots of people in the second bucket who are utterly rational. Science doesn't become policy. Science informs policy, because policy has to take into account societal preferences, willingness to spend, what people's priorities are. And you can look at the same research and come up with not only different decisions, but different policies. I've said this more times today than I can count, so apologize if you heard this already, but do you think there's a person left alive who doesn't know that exercise is good for you? I mean, really? Every time they start going on a new kick, as if we got to tell people that exercise is good for you. They know this is not a knowledge dissemination problem. They don't like it. I don't like it. It hurts and it's tiring, and I'd rather rest and play video games than go to the gym. Like, you're not going to convince me by throwing more research at me. You'll convince me by overcoming the things that I don't like. During COVID, I hated wearing a mask because I wear glasses. And every time I wore a mask, it fogged, I couldn't see. And every time I said to a colleague, I hate wearing this mask, they would start lecturing me on the evidence, as if I didn't know what the research showed on masks. I know, I don't. Fix the mask so that it doesn't fog up my glasses. Attack the thing that's meaningful to me, and I might change my mind. But we so just think throwing evidence at people can help, but we also ignore the whole third bucket. They don't like you. They don't trust you. That's a real problem, because there's a lot of evidence from randomized controlled trials that if you throw knowledge at people who don't trust you, it doesn't it doesn't help, it actually backfires. During the Affordable Care Act, lots of people believed death panels were real, that there were going to be secret groups that decided whether grandma would live or die every time she got sick. And it wasn't true. It never was true. And everybody knew it wasn't true. It's called like the lie of the year from PolitiFact. But they found that if you took people who believed that death panels were real and you gave them corrective information in the form of an article explaining that it wasn't, they became more likely to believe that death panels were real. A more recent study, which looked at people that believed that flu shots caused the flu, they took them and they randomized controlled trial, gave some of them corrective information from the CDC that explained flu vaccine can't cause the flu. Those people became less likely to get immunized, because providing corrective information or facts or evidence or research to people who don't trust you makes them more likely to think you're lying. What are we doing every day? We're getting on social media where our goal is to find the tweet or the TikTok that's going to suddenly convince everyone who doesn't agree with us to agree with us by providing them facts and information. That's doing harm. All those people who don't trust you are becoming hardened against your way of thinking and your data and evidence if you don't first build the trust that's necessary to then engage in corrective behavior. That cannot be done at scale, because what does building trust require? It requires empathy. It requires listening. It requires long-term relationships. It requires interaction, none of which is experienced on social media. None. It cannot even be done at scale. It has to be done at a local level. I had lots of patients who refused vaccines when I was a resident in Seattle in the late 90s. They were very different than the people who refuse vaccines now. But the way that I got them to change was not to bombard them with evidence at the newborn visit. It was to start building a relationship that would only grow at the 2-week visit, at the 1-month visit, at the 2-month visit, at the 6-month visit, at the 1-year visit, until they had enough trust in me that I listened, that I took their concerns seriously, that I asked questions, that maybe then I could start working on changing their minds. We don't do that enough. We don't want to talk to people who disagree with us. We don't even want to know often people who disagree with us. And more than ever, I see people starting to refuse to even engage in healthcare with people who disagree with them. That's bad. It's really bad, because the only way we're going to change people's minds is to start looking at the people in box 2 and box 3. And they require a completely different approach than the people in box 1. And almost all the people we're talking to online already are on our side with box 1. They already know the data and the evidence. They know vaccines work. They know Tylenol doesn't cause cancer or doesn't cause problems in moms or babies. They know this stuff, but they don't trust us. And we got to work on building that trust. Each of you is a leader in some way in your profession. You shape how evidence is produced, how innovation is deployed, and how health information can reach people. You don't need anyone's permission to do this better. In your practice, you can today present absolute accurate numbers and risks, as well as the relative ones. You can acknowledge what we know and don't know and how sure we are. You can name trade-offs out loud. These are the risks, these are the benefits, and it's up to you to make a choice. And if they don't want to make a choice and they ask you to because they trust you so much, it's totally fine to tell them what your choice would be and what you think. They've already given you the trust at that point. That's fine, but make sure you have that trust first before that you tell them what to do. In your organization, you can champion innovation, but with guardrails. You can demand that equity not be an afterthought. In your research, you can ask, how will this matter to patients? How will this matter to everyday people? And are we actually doing research that's designed to solve a problem or just point another one out? You can build in evaluations from day one of everything that you do. This is not work that we can ignore. No single discipline owns evidence or communication or trust. We all do together, and we can build them together or we could lose them together. I started today with a bunch of numbers. I threw out that drinking one drink a day will raise you 0.7% or 0.5% or 7% or 18% or 4 per 100,000. They're all correct, but which numbers we choose to present will have a very different decision. What they wrote when they said there is no safe amount of alcohol is true. What I also wrote is true. But one of them was designed to treat people like they might make conscious decisions that are rational on their own and to try to give them as much information as possible so that they could do so. And the other was designed to make them afraid. And it's important that we recognize the difference. We've spent too long trying to make headlines when we should have been trying to improve understanding and build in trust. The erosion of trust in health institutions didn't happen overnight. It happened one fear-based message at a time, one oversimplified recommendation at a time, one cherry-picked study at a time, one refusal to acknowledge a trade-off when a reasonable one existed. But here's the good news. We can rebuild trust exactly the same way. We can have one honest conversation at a time. We can have one study that's designed to solve a real problem. We can have an innovation that's deployed with guardrails so that we make sure that it works as we scale it up. We can have a moment of saying, here's what we know now, here's what we don't know, and here's what it might mean for you and what you might want to think about. That's work. It is hard. It is not easy. It is much, much more difficult than fear-mongering. It takes much more time than it does to write a headline or a social media. It will not go viral. But it will, and it is what the people we serve actually need. Every one of you in the room has the ability to do all of this in your research, in your practice, in how you deal with others, in how you talk to patients, and how you talk to colleagues, and how you talk to policymakers. You don't need more education or a new tool or a new grant or a new title to do any of this. You just need to have a commitment to communicating with patients as honestly as you investigate what might work and what might not. Science that people can trust isn't a slogan. It's a practice. And it starts with each of us deciding that the truth presented with context and care is always enough. Thank you so much for inviting me today. I really appreciate it. I'm more than happy to take questions, and it's been a pleasure being here. Thank you.
There is a reception outside that's being set up. So in that meantime, if there are questions, please, Dr. Carroll is here. Any questions from the audience? Dr. Jafrida.
Well, thank you so much for this very refreshing talk. I was wondering if you can comment on the role of pharmaceutical companies that sometimes, maybe more often than what we want, they prosper from spreading the fear that certain study, divulgate. And also, how do you rebuild the trust in a world that, as you said, jumps on social media and everybody, without any filter whatsoever, is free to say whatever they want with no screening?
Let me answer the pharmaceutical question first. And this is going to sound terrible, but some of my best friends work for pharmaceutical companies. I live in Indianapolis. I know lots of people that work for Lilly, including pretty high up, and we have discussions all the time. I think some medications are miracles. And some things that I think GLP-1s are miracles. I think the COVID vaccine was a miracle. Mercaptopurine, the drug that I take, I'd pay any amount of money for it. I don't care. It's a miracle. On the other hand, lots of drugs are just Me Too drugs. The problem is that we have I think we've set up a system which does not, align our incentives and what we want out of what we reward. And so we don't reward miracles, we reward volume, and we reward chronic illness, and we reward if you can just find something fancy and new. If it's a Me Too drug, you already have a prescribed audience, you just got to convince more people to take it. We could choose policy-wise to align that better. I believe there are some bad actors in the pharmaceutical industry. I really do. I also believe a lot of people, just like any other company, are trying to make money. And that is American, and that is how we've set up the system. And in all facets of the healthcare system, everything is aligned around like, how do we increase revenue? How do we drive revenue? How do we, get more money? Because we all believe we're doing good, including the pharmaceutical companies. What would I suggest? We could realign the ways that we reimburse for money. Right now, the people who have to pay for drugs are the sick people. So we've set up a system where the sick people are the ones that have to pay for the research and everything else. That doesn't seem like the best way to do it. We could probably come up with ways to fund research publicly if we consider it a public good, or to reward them in prizes or other ways for inventing miracles, or changing the way that we pay for drugs so that we, something like reference pricing, where we say, we'll pay for this, this works great and it's cheap. And if other people want to pay more for it, that's your choice, you pay for it. It won't be popular, but it would work. I mean, reference pricing does work in other areas. So I will not blame just industry, although I will absolutely blame them for Me Too drugs. I think that's just it's hard to defend that at all. Your second question was, how do you rebuild trust in an environment where everybody is on social media and doing these things? One is like, it can only be done locally. We have to recognize we don't all have the power to save the world. We have the power, however, to influence people who trust us. And the more local we are willing to work, the more effect that we are going to have. I probably have the most effect, with patients that I had over a long period of time and who trusted me. I probably have a pretty solid effect or chance to change the minds of my good friends and my family who trust me. And at IU during the pandemic, what I'm most proud of is not the testing schemes we set up or how we rolled things out. It was our willingness to engage with the public. I did a webinar every week, at least every week, which was an hour. Anyone could join. We had thousands of people show up, and I would answer any question anyone asked, period. I didn't care how angry it was. I didn't care if I had to answer the same question 1,000 times. I didn't care if I had to go over things again and again. It didn't matter to me because it was all about trust. It was, I hear you. Let me give you my best answer. And let me say, just know we're making this up as we go. And that it might change next week. And if there's new data, I will give you a different answer. But if you keep asking me the same question, as long as the data is consistent, I'll give you the same answer. And I built up an enormous amount of trust that made people listen. And I would say, when they said, why is it 6 feet? I'd be like, I don't know. There's no evidence for that. In Europe, it was a meter. Why is it 6 feet here? Because we don't follow the metric system. But there's no science. I know that being further away is better. We have collectively decided that 6 feet is a reasonable answer for us today. But I swear, if somebody had started doing a study and proved 4 feet was the answer, I'd change my answer to 4 feet. And if it turned out that it didn't matter at all, I'd change my answer again. But I would say, we can only go on what we know at the moment, and this is what we know. If we're wearing masks this week, you can ask me every week if we need to keep wearing masks, and I will tell you when we don't. And I will tell you why that is, and I'll explain it. And that listening, that talking built it, but I couldn't have done that nationally. I couldn't have even, people started doing this at the state level. It's never going to work. It could work at IU because I was local enough that I could wrap my arms around it and because I was really willing to make that my job. But there's lots of instances, if you're willing to set your sights low enough, that you can work on people like this. I live in a red state. Lots of people disagree with me. Lots of my friends disagree with me. They're my friends. And there are things that I know, I'm going to let that pitch go by. And then there are things on which I'm going to engage, but I wait for the right moment, the right time, and then I strike. I have told many people today, I hate supplements. I just hate them. I've written so many columns against supplements. All my friends take supplements, all of them. They're all sure that this or that one is, and I don't engage with any. If they ask me, I'll tell them what I think. They've learned not to ask me. And I don't feel the need to correct them all the time. There's no point to it. I will sabotage the trust and the relationship that I have. But too many Americans want to be right. And they want people they disagree with to be wrong. And they want to fight. And they want to get angry. And that does not change people's behavior. It might make you feel good. And it might make you viral, and it might get you more followers on social media, but if our goal is to change people's behavior, we have to engage it in a completely different way.
So we have a question online. I mean, in fact, there are multiple questions, but I don't know if we can get through all of them. So I'll start with the first one. I think that maintenance of patient dignity and choice also play a role in this. Patients should be seen as partners. That is a word we use, but not one we practice actively. Patients are not non-compliant. They make choices they have a right to make. What are your thoughts?
So, that's a really great question. And I like the fact that you brought up non-compliance, because our first instinct is often just to blame the patient, as opposed to asking them, why are you non-compliant? Something like 1/3 of Americans avoid care in the United States because of cost. They don't fill a prescription that they've been given. They don't get a test that's been ordered, or they don't go to a referral that's been made because of cost. Right off the bat, that makes you non-compliant. Is it their fault that they couldn't get? No. Maybe the side effects were bad. Maybe it was too difficult, like a 5-time-a-day regimen. There's lots of reasons, but that requires asking and discussing, because it might not be a knowledge problem. It could be a trade-off problem. And that requires a very different approach. But just placing blame and then going straight to the data and the evidence about, like, if you don't take it, this is going to happen, then that's not going to work. And it's also a way to lose trust. So I try very hard whenever anybody asks me for medical advice, because I really don't practice these days, to say, I can tell you what I would do, what decision I would be made, and my thought process and how I made that. Weighing the benefits and the harms and why I would make the decision I will. But you need to make your own decision. And so you may see those benefits and harms different. You may think that a 0.0001% chance of death is too high for you. I like to ski. That's risky. Other people might not. I like drinking, bourbon. I do. And so, I will have an occasional drink. Other people don't want to drink. Those are all rational choices. The number one killer of kids, again, is cars. We don't say, therefore, no one can drive. We try to make driving safer. We try to limit those deaths. But the optimal number of deaths is unfortunately not 0, because that would mean no cars, and way more people are going to die not getting somewhere, like the hospital, if we don't drive. We have to find a balance. Different people are going to make different decisions, and we have to be able to respect that and talk about why they make those decisions.
Thank you. Is there a question here? And we'll make that the last question. I think we are over time.
Dr. Carroll, thank you very much for the presentation, especially the thought-provoking part of it. I'm really in agreement with trying to better the research that we publicize and communicate to people. The question I have is a philosophical one. In thinking of someone who's learning to do research, what do you think if conducting research that's maybe fear-mongering, but eventually leads to the skills of them to be able to answer the questions that identify what you're trying to call for? What are your thoughts on that?
Yeah, so it's like, look, cohort studies are important. They are sometimes the way that we can identify risk factors or things that might be associated with good, which we should then follow with further studies. So I applaud the fact that I've done surveys in my career. I've done cohort studies. I've done case-controlled trials. But I never thought I should be on Good Morning America talking about my case-controlled trial. Like, that was just sort of hypothesis generating. We need to get better about recognizing that it's okay to do that research because it's either part of training, or to do that research because we think it's investigating something new. But I lose my mind because it feels like 2 or 3 times a year, someone from the T.H. Chan School of Public Health at Harvard publishes another case control or cohort study saying that all children are dehydrated. And it's over and over. And I'm like, you have not advanced anything. It's a terrible study. It's a terrible study design. But you know what they should have done? They shouldn't have called the New York Times and told them that they need to highlight this new study because they're from Harvard. They should have recognized this isn't really that big a deal. And it's like clean water has never been as free or as ubiquitous as it is right now than at any other time in human history. I promise you, people in America are not dying of dehydration. It's not happening anywhere. And we got to stop. But everybody wants to be famous. And people will say, but my university wants me to say this. There was a study years ago that I remember the headline said, we have proved that people are more likely to get colds in cold weather than in warm weather. And I was like, I know that's not true. I know there have been randomized controlled trials that are unethical to test this. But when I dove into the study, it was an absolute, like almost cellular level study where what they found was that some viruses were more likely to replicate at 98.6, I'm sorry, were less likely to replicate at 98.6 degrees than at like 96.8 degrees. And you know why that is? Is because they do a better job of like colonizing our nostrils, where it's slightly cooler, than our internal core temperature, which makes sense. Those viruses like to be in the respiratory tract. They don't want to be like 98.6 degrees. They want to be, that had nothing to do with whether or not you're more likely to get infected. But they wanted to be, how did the press office? The university wanted the press. They wanted the press. And so they're like, oh, we showed in colder weather. It's garbage. It's absolute garbage. But that's the fault of the media. It's the fault of the press office. It's the fault of the scientists. Like they should have said in every interview, like, no, that is not what this study shows. It shows that these viruses we're studying are happier in your nose and your respiratory tract than deep inside your body. But we fall prey to this all the time, and we can be better about it. So yeah, simpler study design should exist. They have a place, and they absolutely have a place in training. But we have to be better about owning, what we've solved with our own two hands, and be more respectful of what we're contributing to the larger scientific endeavor, and not oversell our own work.
Great. With that, we'll thank Dr. Carroll. Sorry that we couldn't get to all the questions, but thank you, Dr. Carroll.